Good afternoon, and I would like first to thank Hugues for the very kind invitation. I'm delighted to be here with you today. So I will be talking about another leukemia, which is adult T-cell leukemia lymphoma, or ATL. So as you know, this disease is secondary to chronic infection by a retrovirus, HTLV1, and worldwide we have 10 to 20 million HTLV1 infected individuals. You can see the high endemic areas on this map, and lifelong, around 5% of infected individuals will develop adult T-cell leukemia, and usually after a very long latency period from 20 to 50 years. So ATL is an aggressive malignancy of mature activated T cells that has a very poor prognosis, basically because of severe immunosuppression and opportunistic infections, a little bit similar to HIV-infected people, as well as to a intrinsic chemoresistance of the malignant cells. And as you can see here in the WHO classification, ATL is classified as a peripheral T-cell lymphoma. Guess why? And however, you can see here on the map that it has the worst prognosis of all peripheral T-cell lymphoma. And you can see here the largest published series of ATL from Japan that was published in 1992, that was published in 2015, and still you can see that 5-year survival was 5% and barely moved to a little bit less than 10% in the aggressive forms of the disease, which are the most frequent. And even for the so-called indolent form of the disease, long-term prognosis is poor, whether people are on watch and wait, like for CLL, the green curve, or treated with chemotherapy, the blue curve. So multiple chemotherapy regimens were tried for ATL, those used for treatment of acute lymphoblastic leukemia or non-Hodgkin lymphoma, and CHOP-like and many others. Even the most aggressive, what is considered standard of care in Japan, the LSG-15 regimen, is producing complete remission in less than 50% of patients, median survival of 10 months, and 4-year survival below 10%. So some hope with targeted therapy in ATL, monoclonal antibodies, and mostly mogamulizumab, which is targeting CCR4. And this drug gave some interesting response in relapse patient. However, unfortunately, when it was tried in a randomized trial against, chemotherapy alone versus chemotherapy plus the monoclonal, you can see progression-free survival and overall survival curves not moving at all. So after more than 30 years of research on ATL therapy, because of the high tumor burden, of somatic mutations, the efforts to directly target ATL cells with chemotherapy, monoclonal antibodies, or small molecules have failed, and unfortunately will probably continue to fail to cure ATL. So what else to target if we cannot target the leukemic cells? One aspect is that ATL never occurs outside the setting of HTLV1 infection. So potential targets are to target the immune system, antiviral immunity through vaccine or allogeneic stem cell transplant, as well as to target the viral replication or the viral oncoproteins. So regarding allogeneic stem cell transplant, you can see here the Japanese nationwide study and the EBMT retrospective studies are both showing that allogeneic transplant is potentially curative. 1/3 of transplanted patients can be cured and have a long-term survival. Unfortunately, less than 10% of ATL patients will reach to transplant. So overall, we're curing 3 or 4% only of patients. It works in whether patients are in complete remission or partial response at CR, and prior monoclonal will increase morbidity, so it must be avoided. So overall, we have a leukemia that is due to a retroviral infection, and within the retrovirus, we have the transactivator, the viral oncoprotein called TAGS, which is quite similar in structure to that of HIV. So why not to try to target the leukemia by targeting viral replication or by targeting the viral oncoprotein? So these were, in 1995, we published with Olivier Hermine the first report in the New England Journal of Medicine about using the combination of zidovudine and interferon alpha as antiviral therapy for ATL, and showing a high response rate in relapsed and newly diagnosed patients. Then in 2010, we reported a worldwide meta-analysis on more than 250 patients who received AZT interferon, showing, you can see here, the median survival, a 5-year survival of 14% with chemotherapy, moving up to close to 50% for patients who received only AZT and interferon without any chemotherapy. And to rule out any selection bias due to the retrospective nature of this analysis, we performed a multivariate analysis showing that only the ATL subtype as well as the first-line therapy is affecting overall survival with a hazard ratio of 0.55 and a significant p-value. So this was an important step forward. Unfortunately, you have seen that still more than half of the patients are dying from ATL, and also with AZT interferon, it is not curative. You have to continue treatment forever, and interferon forever is not fun. And if you stop even after several years of disease control, the disease will come back. So why not to try to target additional viral targets, and particularly the viral oncoprotein TAGS. So TAGS has multiple functions in the cells. It affects multiple transcription factors, activating NF-kappa B, CREB, and others. It blocks apoptosis. It interferes with the cell cycle control, and it blocks DNA repair, allowing accumulation of a large number of somatic mutations. So first, to understand how all of these function can be produced by one oncoprotein, where we studied the post-translational modifications of TAGS. And to make a long story short, what we have shown is that TAGS is subjected to polyubiquitination by ubiquitin K63 in the centrosome, allowing to recruit NEMO and to activate the I-kappa B kinase and the NF-kappa B pathway. Similarly, TAGS is subjected to simulation in nuclear bodies, and this will recruit transcription factor, leading to transcriptional activation. And finally, the TAGS is also subjected to K48 polyubiquitination, resulting in proteasomal degradation. So this is a protein that can change its clothes to have multiple intracellular functions, and that is key for transformation of ATL. And actually, TAGS is a quite interesting therapeutic target because chronic HTLV1 infection, TAGS transgenic cells, and TAGS transduction in stem cells results in adult T-cell leukemia, with all showing what we have in patients: organ infiltration, circulating malignant cells, hypercalcemia, and NF-kappa B activation. However, in ATL patient, as well as in all these experimental models, TAGS is expressed at a very low level in general the tax protein is undetectable, and the tax transcript, this is a logarithmic scale, is 1,000-fold less than what you see in cell lines that express tax. However, despite the fact that tax is expressed at a very low level, ATL cells are addicted to tax expression. And you can see here whether we're taking cells that express tax protein or cells that do not express tax protein. Tax silencing results in selective killing of ATL cells. And a recent work using live cell imaging showed that tax is actually transiently expressed at in 1% of cells at a time, and then they will silence tax, and other cells will express 1%. And the reason for that is double. A high level of tax will induce cell senescence, and tax is highly immunogenic, so keeping tax expressed all the time will result in cell killing by the CTL. So while looking for how to target tax, what we have shown is that the combination of arsenic trioxide and interferon alpha is highly synergistic in inducing tax degradation by proteasome, resulting in shutoff of proliferation gene, cell cycle arrest, and apoptosis. And regarding the biochemical pathway of tax degradation, you can see here that it is strikingly similar to that of PML RARA degradation by atraarsenic in APL, involving PML-dependent simulation of tax and PML nuclear bodies, followed by recruitment of RNA4, ubiquitination of simulated tax by this sumo-dependent ubiquitin ligase, followed by proteasomal degradation. So then moving to preclinical models in mice, this is a very nice model in tax transgenic mice. We showed that actually the combination of arsenic and interferon can cure murine ATL. So you can see here that in general, the leukemic mice will die within 1 month. Single agent arsenic or interferon in green or in yellow will double the survival, but the combination, if you give 1 cycle of treatment, will cure 40% of the mice, and if you give also a short consolidation, 80% of the mice are cured and live for more than 18 months and become tax negative entirely. And to understand the mechanism of this curative effect, actually what we've shown is that it is not through cell cycle arrest, it is not through induction of apoptosis, but it is through selective targeting of the LIC, the leukemia-initiating cell activity, and using serial transplantation. You can see in pink, you have the number of leukemic cells and injected in mice in serial transplantation, and the time for cell death reflecting LIC activity. And basically, if you inject 10 cells, you kill 100% of the mice. If you inject 1 cell, you kill 30% of the mice. Now, if the donor mice were treated only for 3 days with arsenic interferon, you can see that you need to inject 10,000 cells to kill 100% of the mice, demonstrating that you have a decrease of LIC activity by 500 to 1,000-fold. And in tertiary transplanted mice, you totally abrogate the LIC activity that you can see here versus tertiary mice from untreated primaries. Interestingly, adding a proteasome inhibitor, bortezomib, or PS341, to arsenic interferon in the treatment of the primary mice by blocking tax degradation will basically block the effect, and the tertiary mice will die from leukemia as if the proteasome inhibitor is protecting the LIC activity. So you can see it here schematically on this model: serial transplantation, rapid tumor growth, and mice deaths from leukemia, treatment of primary mice with arsenic interferon, slow tumor growth in secondary mice, and delayed apoptosis, and no tumor growth in tertiary, and co-treatment with proteasome inhibitor as if you gave no treatment at all. So basically, in ATL cells, we have a tax-independent short-term proliferation followed by a tax-dependent long-term self-renewal, which is responsible for the LIC activity. So to try to understand how the LIC activity, ATL LIC activity is lost, we treated primary mice with arsenic interferon for 3 days, injected into secondary mice that were sacrificed on a weekly basis to try to see what happens in these secondary mice that, and basically what we have seen, and I think that this, I did not find a similar situation in other tumors, is in these untreated secondary mice, we have a biphasic growth. So you can see that initially the tumor will grow to cause massive splenomegaly, massive leukemic infiltration, and suddenly spontaneous tumor regression over 2 weeks, followed by another tumor regrowth. This is the tumor bulk. Similar findings were obtained for spleen weight, circulating white cells, and organ infiltration. So we try to dissect what happens. So for this spontaneous tumor regression, we've seen that it is accompanied by a shutdown of telomerase activity, induction of PML transcript, and formation of PML nuclear bodies, activation of P53, followed by senescence. This is DEC1 expression, and this is beta-gal senescence. So we have PML, P53 associated senescence responsible for the tumor regression following shutdown of telomerase. But then the tumor will regrow. And actually, we're showing that the tumor is regrowing because you have induction of TRF2 and recruitment of TRF2 to PML nuclear bodies. And recruitment of TRF2 to PML nuclear bodies is responsible for alternative lengthening of telomeres. And as you can see here, the cells will use ALT to lengthen their telomere and allowing them to escape from senescence. But then when they escape from senescence, they become progressively apoptotic and they lose their LIC activity. You can see that the LIC activity is maintained initially in these untreated secondary mice, and it is only at the late stage when we have the tumor regrowth that we have the loss of LIC activity. So to understand how this LIC activity is lost, without any additional treatment. So basically, if you see here in green, the LIC activity is maintained initially, which means that if you remove the leukemic cells from the untreated secondary mice, from the microenvironment, and you put them into new SCID mice, that tumor will grow again. You restore LIC activity. If you keep them in their microenvironment, they will lose the LIC activity. And in the microenvironment of SCID, we have innate immunity. We have macrophages and NK cells. We don't have T and B cells. So we started to repeat the same experiment. We decided to repeat the same experiment in non-SCID mice, which are lacking NK cells and have impaired macrophage function. And you can see that in dark blue, in these mice that lack innate immunity, you maintain the LIC activity. So which means that innate immunity is required for LIC loss. And actually, we've done the same for treatment of primary mice, and also for primary mice, if you do it in NOG, you don't kill the LIC activity. And actually, what we showed is that at these late time points, that arsenic interferon promote the production of pro-inflammatory cytokines by innate immune cells. You have here sorted cells. In red are the leukemic cells that are CD25 positive. In blue, the microenvironment cells of the host. And you can see interleukin 12, interferon gamma, MCP1, and MIP1 alpha, all coming and probably responsible for the delayed apoptosis that we have seen. Conversely, in the leukemic cells, what we have seen is that we have an early and rapid shutdown of interleukin 12, which is a cytokine produced by ATL cells. You can see here as early as week 4, at the time where we had the peak of the first tumor growth, you have a shutdown of IL-10 production, as well as phosphostatin 3, which is the downstream signaling of IL-10. And this loss of IL-10 is responsible for the loss of LIC activity, also because adding recombinant IL-10 will rescue ATL-LIC. As you can see here, you restore splenomegaly, and you restore rapid death of the mice from leukemia. But this is by adding external recombinant IL-10. How about the physiologic situation? So I will spend some time on this experiment where we have primary ATL SCID mice that harbor tagged transgenic cells. We can take 1 million cells from these untreated primary, and you put them in secondary that will die in 3 weeks. You can take 10 cells only from these untreated primary, put them in secondary that will die in 70 days. Then you can treat the primary with arsenic interferon and take 1 million cell, put them in secondary, they will die in 2 months. But then you can also take 1 million cell from treated primary and 10 cell from untreated primary, put them together, and the mice will die in 3 weeks, which means that 10 healthy cells are able to save the LIC activity of 1 million treated cells, or 1 cell can save the LIC activity of 100,000 cells. And also conversely, anti-IL-10 monoclonal antibody will prolong survival, decrease splenomegaly, decrease the LIC activity, decrease mTOR, induce TRF2, decrease phosphostatin 3, so reproducing all the effect that we have seen with arsenic interferon treatment. And so that was in mice. Now moving to ATL-derived cells, we showed that IL-10 secretion is at least in part tax-dependent in ATL-derived and HTLV1 transformed cells. You can see here that SH tags will shut down IL-10 production, and SH tags or SH-IL-10 will shut down or decrease, significantly decrease telomerase activity, significantly increase PML transcripts, and results in recruitment of TRF2 to PML nuclear bodies. And finally, when doing the triple combination of arsenic, interferon, and anti-IL-10 monoclonals, you can see here the very long survival with a very short one-cycle treatment of SCID mice, whereas you only have some prolongation of survival, but all the NOG-SCID mice that do not have innate immunity will die from leukemia. So moving back to patients in a clinical trial on 10 ATL patients treated with a triple combination of arsenic, AZT, and interferon, you can see here 100% response rate, including 70% complete remission rate. You can see the skin lesion rapidly disappearing. And contrary to AZT interferon alone, where when you stop treatment, you have early relapse of the disease, when stopping after arsenic interferon AZT, you have half of the patients who maintain continuous complete remission up to 18 months after stopping treatment. And interestingly, in these patients, we have at baseline, also similar to what we have seen in the mice, high level of interleukin-10 and low level of interferon gamma. And following treatment, you can see interferon gamma going up and IL-10 going down. And these are results from Olivier Hermine group in Necker, also showing that the use of arsenic interferon as consolidation therapy after first-line therapy results in a significantly long overall survival, unprecedented survival of more than 3 or 4 years for aggressive ATL patients. And this was accompanied by a clonality assay by elimination of the leukemic clone. So basically, in terms of model, following HTLV1 infection, we have clonal expansion due to transient tax expression. We have a multi-step leukemogenesis resulting in ATL development with transient tax expression or tax silencing. And we have a continuous de novo infection with high levels of tax expression. So these cells, as well as the continuous viral replication, will result in production of IL-10 and potentially other factors that will have an autocrine or paracrine effect to maintain LIC activity of ATL cells through maintaining telomerase activity. And at the same time, IL-10 is capable of blocking innate immunity and potentially adaptive immunity. And this is where the different therapies can work. AZT interferon can block the de novo infection. Arsenic interferon, by degrading tags, will block IL-10 production, and anti-IL-10 monoclonal can work here. Finally, I would like to thank all those who did this work at the American University of Beirut in Lebanon, and as well as a long list of external collaborators. But I would like to highlight 30 years of friendship and collaboration with Olivier Hermine and Hugues de Thé. Thank you for your attention.